The number of gastroenterologists that are in active practice has been steady for almost 20 years now. So we're not increasing our workforce, despite the fact that the population is increasing in terms of age and the demands on gastroenterology are higher. So we have to learn how to work smarter. We have to learn how to work in teams. So having advanced practice nurses, nurse practitioners, physician assistants, RNs helping us in a team-based care that can leverage what we do to a bigger population is going to be absolutely critical. But those are very complex structures to put together, and physicians are not yet used to that. We're learning very quickly, but it's really important that we understand that and lead. Yeah, it's a very rare patient that comes in with a diagnosis. To many doctors, it still remains a diagnostic challenge, and putting all the pieces of information together is what makes a physician, a nurse practitioner, a physician assistant, a provider unique from Watson computer, for example. Now, the interaction of artificial intelligence, computer intelligence, and physicians is now becoming very exciting, actually, and that type of partnership is going to help. It's clear that nobody can remember all of the things that we need to know. So I think pushing the boundaries on that is going to be a very exciting field in the future. Just in the last year, we've seen multiple drugs come out that can essentially cure hepatitis C. And that's just been a tremendous boon. That has been the prime reason for liver transplantation across the country. And it's estimated that in 5 to 10 years, certainly new hepatitis C is going to be diminished or cured, and the residuals of cirrhosis and problems like that will begin to decrease a lot. But it comes at a huge cost because the cost of treatment is so high. We heard a lecture today on biologic medications, for example, will be much more of a factor in the years to come in terms of the spend on pharmaceuticals, and that's going to be a huge economic pressure. So understanding how to apply those in the right patient at the right time is going to be critical. It works spectacularly in some patients, particularly patients with chronic infections with C. difficile, which is an organism that can be just devastating and life-changing, and going through multiple rounds of effective antibiotics, but it comes back and recurs. And with the fecal microbiome transplant, for example, we're seeing cures that are just absolutely miraculous. Well, the human microbiome is a source of just tremendous interest and research focus now. We're made up mostly of bacteria, frankly. Many more bacteria organisms than the cells in our body. And to think that they were just a passive component of our body isn't true. They're a very active component. So they influence diseases, chronic diseases, probably diabetes, probably heart disease, probably cancer risks, certainly inflammatory bowel disease. All of those things we're beginning to peel back and understand how some of the things that are in nature can be used to really help either restore health or maintain health. I think Ebola is a wake-up call to the fact that there are lots that we have not cured or at least gotten rid of infectious organisms. And Ebola is going to be one of a number of different viruses, bacterial infections, fungal infections that we're going to continue to be confronted with. And that happens to be an incredibly lethal and devastating and highly transmittable infection. And so it already has changed our conversations, how we talk to patients, how we screen them, how we set up our clinics, how we set up our hospitals. So we're going to see more and more of that.